Hello everyone. Today we're going to be talking about some of my PhD work. This is a quantitative study, and if you may remember, I did put up a presentation about the qualitative work that was done during my PhD years. This study was looking at the reasons for and for not informing illness perceptions and the psychological adjustment among caregivers who were informing and not informing to their cancer patients about their true diagnosis. So just to give you a quick background about what is this family's role in medical decision making. It's important to understand that in most of these collectivist countries, such as India, we follow a family-centered decision-making style where the family precedes the patient. So the family becomes more important than that individual person. So many times the family makes the decision on what education the kid would pursue, or what partner would this person get. So similarly, in a medical scenario, the family makes a decision about treatment or any other kind of illness related decision rather than that individual patient. So many families in India, they choose not to inform the patient about their true diagnosis. And how they do this is by giving the patient a very plausible alternate explanation. So if the patient has, say, bowel cancer and they have pain in their stomach, they'll say that, oh, you know, you have a stomach ache and you need slightly more complex or special treatment, so we brought you to this bigger hospital. Now, the question really is, how frequently does this occur? And whether it's reflective in the number of patients who are aware and not aware, right? So in terms of the number of families that withheld the full diagnosis, a quick background literature showed us that 66% in Turkey and 58.5% in Japan caregivers were withholding the diagnosis. Now, this is research that is more than 10 years old now. Our more current research has shown that it still splits into half in terms of the disclosing and the not disclosing families. What's interesting is that these findings are reflected in how many patients are being aware or unaware of their diagnosis. So as these findings show you that, again, nearly half the patients are not aware of, or more than half the patients are not aware of their true diagnosis. So the family's role in disclosure decision making appears to be fairly important. But what's very interesting is that some caregivers were informing and some were not informing. So there seems to be a slight disparity or a difference between the caregivers who were telling and not telling. It's not like a uniform decision that was made from that particular culture or country. So that made us very interested to understand what is really going on, what differentiates between caregivers who were telling and not telling, really. So we looked into the factors that were distinguishing between caregivers who choose to disclose and not disclose to patients about their cancer diagnosis. And we were also wanting to look at what are the most salient reasons for caregivers to disclose and not disclose. So the methods that we used, we interviewed 319 caregivers, of whom 154 were disclosing and 165 were non-disclosing. So you can right away see that we had more non-disclosing caregivers than disclosing caregivers. Now, I'd also like to pause over here for a moment and say that we had identified a caregiver as the primary caregiver. That is the person who the patient identifies as the most important person when it came to treatment, medical decision making, and was present in most consultations with the physician or any other healthcare staff. The measures that we used were the BIPQ, the HADS, and a reasons for and for not informing checklist. Now I'm going to talk about this last checklist for a while longer. just to sort of give you an idea about what this checklist is all about. So we wanted to look at the salient reasons for choosing disclosure versus non-disclosure of the cancer diagnosis among the caregivers of these patients. So we conducted this elicitation study where we looked at, we interviewed 15 caregivers, of whom 12 were male, in the same hospital where we would be then conducting our larger quantitative study. And we asked these caregivers to list every single reason they can think of for disclosing and for not disclosing to their patient. What we came up with was 44 reasons for and 70 reasons for not disclosing. And we had two investigators, myself and Paul Norman, who looked through these lists very carefully, and we individually and then together had devised 10 categories for disclosing and 9 for not disclosing. Now, each reason of the 44 and 70 reasons were then assigned per category independently by these investigators, and we came up with a kappa score of 0.76 on the reasons for and a kappa of 0.77 on reasons for not. So it's a pretty high level of agreeability between the two investigators in terms of assignment of the reasons in each of these categories. So we had a cutoff of 25% for inclusion. And what we ended up with was, that is, there should be at least 25% of reasons being allocated to that particular category. What we came up then was with 6 reasons for and 6 reasons for not disclosing. And then what we then did was we used 3 example quotes to illustrate or to expand on that particular kind of reason. So we used 3 example quotes per reason. So we had 6 plus 6, 12 into 3. Okay, so 36 items. And some example items for you in the reasons for disclosing, say for example the emotional well-being reason, we had these 3 quotes. If we hide it, the patient will get more scared, and so on. And in the reasons for not disclosing, say for example, a reason could be longevity and curability, we came up with the quote from a caregiver who says, if we tell, the patient will not cooperate and their health will deteriorate, and so on. Now, coming back to the method of our larger quantitative study, as I had told you, we interviewed 319 caregivers at BIACH and Hyderabad, India, and we used the measures of the BIPQ and the HADS. Now, the HADS is an anxiety and depression scale that's been used quite frequently in medical settings. It's a 4-point Likert scale with 7 items for anxiety and 7 items measuring depression. I want to also now talk a little bit about the BIPQ. So the BIPQ is a scale that's based on the common sense model of illness representations proposed by Leventhal in 1980. It measures 8 core components and 1 component on cause of cancer. And the idea behind the common sense model and the BIPQ is to look at individuals' beliefs about a certain health threat. Okay. The 8 core domains are consequences. So whether the patient feels or the participant feels like there are major or minor consequences of that particular health threat, how long or what the trajectory of this threat is, whether the person has ability to control the symptoms, whether they feel like the treatment is effective in controlling this threat, whether they're able to accurately name name the threat, what was their level of worry or concern about this threat, how well were they able to understand this threat, and what was their emotional reactions to this threat. The reasons checklist comprised, as we had discussed, 6 reasons for and 6 reasons for not telling. It was scored on a 6-point Likert scale, starting from no, not at all important, to yes, very important. So the reasons for disclosing checklist consisted of the reasons of emotional well-being of patient, disclosing because the caregivers did not have control over the situation, then preparing the patient, familial reasons, patient's personality, and longevity or the curability of the disease. In the reasons for not disclosing checklist, again, emotional well-being of the patient, familial reasons, patient's personality, longevity or curability of the disease, barriers to communication, and the disease severity. Now, when we had constructed these scales, what we found was the alpha coefficients were not very satisfactory for the disease severity scale. So we had to break up these into 3 different items, as individual items rather. Namely, the disease suddenness, patient suffering, and not so serious were the items within the scale of disease, subscale of disease severity. Now, a quick overview of the sample characteristics. The caregiver's age was an average of 40 years. The caregiver's gender split into 234 male and 85 females. The patient's cancer stages were between the stage 1 to 4, but we had a large number of patients who were in the 2nd stage of cancer. And the patient's cancer types, we had a large number of breast cancer patients, head and neck cancer patients, and ovarian cancer patients, followed by the stomach, lung, colorectal, cervical, leukemia, NHL, uterine, and other cancers. Now, in terms of our results, disclosing versus the non-disclosing caregivers and patients, looking at first of all the caregivers' demographic details, we found that disclosing caregivers were most likely male, employed, not the child of the patient, and were older. Looking at the patient's demographic and medical details, what we found was that disclosed patients were most likely educated, undergoing a combination of treatments, and had been diagnosed and treated for a much longer time. Now, among the psychological variables, what we found was that the non-informing or the non-disclosing caregivers were more likely to report higher levels of anxiety, depression, had more negative or worse illness perceptions, were less likely to give reasons for informing, and more likely to give reasons for not informing. And all these variables were significantly correlating with our informing and non-informing caregiver groups respectively. Now, we were also interested to look at how the subscales were being scored by both the groups, that is the informing and the non-informing caregiver groups. And what we found was that the informing caregivers were more likely to quote lack of control, preparation, and patient's personality, and were less likely to quote emotional well-being, familial reasons, and longevity or curability as reasons for informing. Similarly, we wanted to look at the subscales of the reasons for not checklist. And what we found, interestingly, was that informing caregivers were also more likely to quote familial reasons, barriers to communication, and patient suffering, and not so serious disease, and were less likely to quote or cite emotional well-being, patient's personality, longevity or curability, and disease suddenness as reasons for not informing. Now, we also wanted to look at how these variables, both the psychological and demographic medical variables, were differentiating between the groups of informing caregivers and the non-informing caregivers. So basically, we wanted to look at what differentiates between these two groups. And interestingly, what we found was that the reasons for and reasons against informing emerged as the most important predictor variables for discriminating between the informing and the non-informing caregiver groups. So what that basically means is that the informing caregivers had more reasons for and less reasons against informing their patients, and vice versa. That means the non-informing caregivers had more reasons for not informing and less reasons for informing. And when we started looking at how we could differentiate between the informing and the non-informing groups in terms of the reasons for informing, what we found, again interestingly, was that preparation and patient's personality were the most powerful predictor variables discriminating between the informing and the non-informing caregiver group. Now what that basically means is that informing caregivers were more likely to quote preparing the patient and patient's personality as the reasons for informing the patients about their true diagnosis. Now, similarly, we did DFAs for the reasons for not checklist. And again, what we found was that patient's personality, as before, and longevity or curability of cancer were the most powerful predictor variables that discriminated between the informing and the non-informing groups. Again, what this basically means is that non-informing caregivers were more likely to cite the patient's personality or longevity or curability of cancer as the reasons against telling the patient about their true diagnosis. So now that we have all our results in place, let's look at the conclusions. So our first aim was to look at the factors that were distinguishing between the caregivers who were disclosing and not disclosing to patients. What we found was that only the reasons for disclosing and the reasons for not disclosing were found to be discriminating between the two groups. So that's really interesting to know that only these reasons were differentiating between the group membership. And now the second aim was to look at the reasons that were the most important for the caregivers who are disclosing and for the caregivers who are not disclosing. Again, what we found was that the disclosing caregivers were more likely to give preparing the patient and the patient's personality as reasons for disclosing. And the non-disclosing caregivers were more likely to give patient's personality and the concern for patient's longevity or curability as reasons for not disclosing. Now, I'd like to hover on this for just a little bit because it seems like patient's personality played a crucial role in caregivers' decision making. Now, when we looked at the items of patient's personality, it was more about what the caregiver knew of the patient. And the other interesting thing that we found was that preparing the patient was an important decision-making point for disclosing caregivers. So clearly, these caregivers wanted to keep the patient as prepared as possible. On the other hand, non-disclosing caregivers had negative illness perceptions about, especially in terms of timeline. Oh, if I tell them, then they will not get cured, that their longevity will be compromised, as reasons for not disclosing. So what are the implications from our study? First of all, it's important to, ring home the fact that the reasons checklist very truthfully reflected the caregiver's disclosure decisions, as it was the only factor that discriminated between the two groups. Now, some suggestions for future research and practice is to look at longitudinal work that would kind of chart the caregiver's reasons over time to see if there's been any change in their disclosure decisions. And also, since disclosing caregivers had suggested that preparing the patient was one of the reasons why they chose to inform them, then it's important to be offering them enough informational support as possible on how to best prepare the patient for the cancer process. The other thing is that as we had seen that the non-informing caregivers had negative illness perceptions. They saw a negative link between disclosure and longevity or curability, and they had a negative idea about the patient's personality. It's important to kind of address this to understand what is making these caregivers have these negative perceptions of the patient's personality or about the relationship between longevity and curability of cancer. Now with this, I'm done with my presentation. So with this, I'd like to conclude this presentation. Thank you very much for listening. And if you have any questions or queries, please drop me an email again. And I look forward to hearing from you. Happy weekend.